Thank you. So I'll get right to it because we have just limited time and it is a pretty vast subject to cover. Um, Check-in words are still welcome. Just we're not going to forego that tradition to just see how everybody is doing very quickly. In the meanwhile, just to quickly recap what we did at the last session, we talked about why communication is an important skill, an essential skill. We talked about different levels of communication and clinical decision making. We talked about milestones along the illness journey where communication takes center stage, which is diagnosis, treatment, and prognosis. We talked about who decides, who makes decisions, and where the care location is, and how communication around that is framed. And of course, we talked about, very briefly, we talked about the barriers that are posed not just by the patient and the family, but also by our own professional biases, by our own fears, and also by what society demands of us. Okay, I will be sharing the full PowerPoint with you later, so you can go over those in detail. So today I'm going to just take you through this. We talked about what the problems are, what the problematic areas are. So now in this session, we're going to go into what can be done when we come across those problematic areas where we have to break bad news of different kinds, where we have to deal with difficult emotions of patients and their families. And as usual, the chat box is open. Please put your reflections, your comments, questions into the chat box. I'll stop from time to time to address any questions that there might be. Okay. Arya, can you tell me if my screen is visible to you?
Yes, ma'am, it is visible.
All right, thank you. So what to do? What can we do? Let's first talk about body position. Okay. Typically, we find, like we've talked about this before here, that there is a power dynamic when you walk into a healthcare institution. And that power dynamic is anyway in terms of, exchange of knowledge, exchange of, or decision-making and all of that. But ideally, even just your body language conveys dynamic, right? So either if there's not enough space for both of you to sit, then both of you stand. Don't sit while the patient or the caregiver is standing. Or don't stand while they sit because it can be a little bit intimidating to have them towering over you. Or you towering over them rather. So either you both sit or stand, and if the patient is lying down, you sit, find a stool or a chair, pull it over and sit down. This is something we don't see in too many places. We have to constantly remind our colleagues, can we please have a chair next to the bed? Because that thing of towering over the patient's bed is there in a lot of settings. Okay, body position is one. The next thing would be the angle of the body. I mean, 1 second, my slides are hanging again. Just give me 1 second, please. This tends to happen only when working absolutely fine all this time. Okay. Body posture is the next one, where you're leaning forward rather than being withdrawn or in an indifferent position. Okay, so leaning forward gently indicates care, it indicates interest, it indicates compassion. And this is on one of our home visits. That was one of our doctors on our team, Dr. Ajmal. And even though this lady was not able to move for days on end, I mean, he engaged, and by the end of it, she had a lot to say to him. Sorry, just excuse me for a second. I'm just going to close this and just give me 1 second. I'm just going to restart my presentation. And actually, I'm just
Sure,
going to,
ma'am. Sure.
yeah, I'm just going to log back in. Okay, just give me 1 second. Sorry about this, everybody.
Hello everyone, hope you are audible and clear. I can see Shanaka nodding. Thank you so much. We are extremely sorry for that. I believe this is second or third time that we are facing similar issue. So sorry for that. So by the time Smriti ma'am joins in, any particular feedbacks or anything you would like to share with us?
I'm back, Shri.
Oh, thank you. I was just trying to steal your show actually. Thank you.
Easy.
Thank
Happy to
you.
hand it over.
Only
Sorry, I'm very sorry about this.
no worries.
It's apparently it's just something that happens with this group all the time.
Exactly. That is what I was also saying.
Can I have screen sharing rights, please? Yeah. So let's hope this works. Shri, I'm just waiting for. Yeah.
Can you just
All
check
right.
now?
Yep. Okay.
Yes.
I'm going to try and go in.
Perfect. Good to go.
Oh, it works. Okay. The third aspect, apart from body posture and position, is touch. And this is a tricky one because it has to be done correctly. We have to be mindful of the context, the culture, gender issues, things like that. Typically, a safe space to touch somebody is on their shoulder from the side. Okay. And if you're sitting in front of somebody, a hand on the knee. Okay, but it's always you have to be very mindful of how the other person is responding. And I remember as a young intern, I mean not as an intern, but as a volunteer earlier on in palliative care, I also, with my training as a psychologist, I was told that you must never touch the person in front of you. And I once found myself in a hospice where this elderly gentleman was sitting there and he didn't have any family. No one used to visit him. He was grumpy. Even after a while, the nurses would be a little bit anxious going and approaching him. And I don't know, for my sins, I was assigned to him. And I was basically just asked to go and check on him every day. And he didn't speak a word of English. I didn't speak a word of Kannada. But I would visit him and I would insist that he get up and brush his teeth. And I'd insist that he take a walk with me because all those nonverbal things. So by day 5, he'd see me coming down the ward and he'd go, oh, and he'd get out of bed and brush his teeth before I said anything to him. But one day when I went up to him, I found him sitting on his bed and weeping. And as a 20-something-year-old, not knowing the language, not knowing what to do, I leaned over and I gently patted him on his back, which kind of broke all the norms of what I was taught. But that is what actually helped in the moment. So you have to, training is one thing, but I think you also have to go with your instinct. And as you start doing this more frequently, you start understanding the appropriateness of it better. But it's always best to also ask for permission. Ask for permission before you touch somebody. Are these suggestions for professionals in a palliative care team or only, or are they applicable to doctors in general? In general. Okay. All right. So open-ended questions. I know psychologists here are very familiar with this. Open-ended questions are basically questions that allow the patient to respond in any manner that they choose. Okay. So these are just some examples. What aspect of the future worries you? Can you tell me more about the pain? Tell me what's been on your mind the most. How are you feeling today? So I'll be sharing these slides with you, so you don't have to worry about taking these down. As opposed to, close-ended questions which only lead to one kind of answer, a yes or no answer, because that's where you don't want to have any more conversation with them, right? So these actually allow for people to respond in a much more a detailed manner. But also I will say that there is something to be said about silence. Silence is a very powerful therapeutic tool. And that is something that has to be cultivated. Not all of us are comfortable with silence. And 1 minute can feel like an hour. But sometimes if you're able to sit in silence with somebody, you'll find that they are encouraged then to answer these questions. Now, examples of close-ended questions. Do you have pain? How will you answer this question? Yes, no. Okay. Where is the pain? It's here. Is it continuous? Yes, no. Do you vomit soon after you eat food? No. Do you feel breathless even at rest? No. So that's it. You cannot answer these questions in more than one with more than one word. And that's precisely what they're meant to do. They're designed to elicit one-word answers so that you feel like you've done your job, you've asked all the right questions, the person has answered it, and you can move on. So you've got what you wanted, but the patient has not been given an opportunity to say anything else. Now, again, many of you are familiar with the concept of active listening, where active listening is not just listening without purpose, but it also involves your response, your participation, again, body posture, leaning in, eye contact, mirroring. Mirroring means if someone leans forward, you also lean forward. If you mirror their body language, not if it's closed body language, please don't mirror that, because then it'll sort of backfire completely, and then that whole conversation starts to close up. Asking questions, open-ended questions, okay? Reflecting back what is said. Okay, so what I'm hearing you say right now is that in addition to your pain, you have trouble sleeping at night. Did I catch that correctly? What I'm hearing from you right now is a lot of distress. I'm reflecting back what they're giving me, okay? I can sense your frustration having to come to the hospital every week. Okay, asking for clarification. You told me that your vomiting or your nausea gets especially bad in the middle of the day. Did I get that right? Or so you're asking for clarification, or you're asking for things like, okay, when you say that your pain is really bad, what kind of pain is it? Is it a burning pain? Is it a stinging pain? Those kind of clarifications are often very helpful in the conversation. And summarizing is an important part of active listening, where you summarize, and not always at the end of the conversation, but even after certain sections of the conversation are done. So far we have discussed that these particular medicines are not helping you as much as they used to. Is that correct? Okay. So what we're here to discuss now is whether we can make an appointment with the physician so that you can maybe change your medication. Is that what you would like? Okay. So, so summarize, reflect, clarify, and then move forward. I'm not spending a lot of time here because we're going into the more essential aspects of breaking bad news. Active listening is very easily researched online. There's a lot of literature about it. Of those resources that you find, I will also try and send you a couple of links. Okay, empathy. So I was saying to somebody recently that empathy is a very tricky, it's a very tricky space for me personally, because as a younger person, I was taught that, okay, let me ask, what is empathy? What does empathy mean? What does empathy mean to you? How have you understood empathy? Or what do people constantly say about empathy? Stepping into other shoes, other shoes, other shoes. This other shoes thing is the most common way of empathy being described. Let me ask you a question. Can you really put yourself in someone else's shoes? You can try them on for size, but they're not your shoes. So this idea of empathy is like the idea of dignity. We all think we know what it means. Okay. Sometimes you can to an extent. Okay, fine. So let me put this different from sympathy, where one is trying to understand what the other person is trying to feel, trying to understand what the person is going through. Yes. Okay. So the issue with empathy is if you empathize with somebody in the way that people say, putting yourself in someone else's shoes, you run the risk of losing your rational clarity about that situation. If you start seeing the world completely through the eyes of the person you're trying to empathize with, you're not your own, I mean, there's a bias that kicks in also, but also you run the risk of having your own perspective clouded by somebody else's. Okay. I'm not saying it's not there. Empathy is a remarkable thing to have. But in a healing profession where you are trying to help somebody navigate a difficult time, you need to hold on to your perspective. So what I personally believe in, and I'm not saying that this is for everybody, I prefer compassion to empathy in this situation. There is a difference between compassion and empathy. I can feel compassion to the suffering of the person with me and still work with them to help them alleviate their suffering. If I start empathizing to the extent where I'm standing there and crying more than the caregiver is crying, how am I helping that person? If I'm sitting and getting emotional about it, am I being of any help? We do empathize. We do feel, we share vulnerabilities. It's okay to cry with your patient, but not if that emotion is just overwhelming you. So personally, this is a personal opinion. Compassion is sometimes the path to take, because you really need a little bit of distance if you really need to be able to assist that person. Oh no, Shalaka. You're empathizing with me. Okay. All right. Okay, I'll come back to that. Okay, so empathy is a very tricky, but using empathizing statements is very useful. Okay, so how do we use empathizing statements? Empathizing statements is things like, I can see how upsetting this is for you. I can see how hard this is for you. Okay, I feel that you are very angry today. These are empathizing statements. I'll take you through a few more of them as we go along, okay? But this is just to say you're validating, you're seeing, and you're not putting any value to it. You're not saying, it's so, don't worry, it'll be fine. You're just saying, you're just accepting it for what it is, and you're saying that I'm here, I see you, and I feel you, okay? So now let's talk about bad news. What is bad news? Now, I'll give you two scenarios where bad news is being conveyed. Okay. Anyone want to volunteer?
Okay. Can I go?
Yes, please. Thanks for those. Yeah.
Yeah. P is starting physiotherapy. He or she has had a bad stroke with left-sided paralysis.
Okay. Life-changing experience, huh? And P says,
P says, Doctor, when will I get completely okay? The doctor responds, I'm sorry to say, but this cannot become completely okay.
okay. How does this land? How does it land with all of you? He was honest, abrupt. Too blunt, too abrupt. Yeah. The case there will be made for honesty, but I was being honest. But yeah, abruptness, blunt. Even the tone seems a little bit off, no? I'm so sorry. Well, if you're going to explain it like that, you're really not feeling very sorry about the situation, are you? Okay. The next, Firdaus, you can carry on if you're okay with that. Okay, the next situation.
Sure. D has been sent to a nurse to be given the diagnosis.
Okay, so in this case, the doctor is not even giving the diagnosis. Okay, it's being sent somewhere else.
The response is, your reports have come today and have been handed to me by Dr. X. You have cancer.
Yeah.
No compassion, no empathy, nothing.
Nothing. Disconveying. Also, because you're the messenger of bad news, actually, it was the doctor's job to do it. I'm just going to hide behind this and say, your reports have been sent to me, you have cancer. Okay. I mean, in real life, it doesn't really happen this, I hope it doesn't happen so, in such extremes. But we have variations of this experience, right? Where in the name of being honest, things are being told to you in a way that lacks empathy, that is too abrupt, that's not taking into consideration people's emotional state at the time, and then just leaving them to deal with it. Actually, when I was I was working at a pediatric cancer ward, and this was my first job, and it was in a government hospital. There were barely any safety, equipment or anything for any of us. And I ended up getting tuberculosis. And I picked it up as a second. I mean, a lot of the children there had it as a secondary. I picked it up. And then I had a bit of a wheeze. I went to this doctor, I remember. And I went in the evening thinking I'll just get my X-ray results and it'll probably be some kind of bronchitis and they'll give me something, an inhaler or something. And I remember the lady, the assistant, looking out of the office and looking at the doctor and saying, it's that tuberculosis case. And I thought, surely she's not talking about me because, can't be me. And I went in and I was actually just told pretty much like that. So here's what's happened. Here is a lesion. This is what it is. So it's tuberculosis. So what we're going to do now is we are going to start you on this medication immediately. Just go to the next door room and get your blood drawn. I was alone. I was 23 years old. And I started crying. And I remember this doctor looking at me and saying, compose yourself, Smriti. I mean, there are treatments for this. I never went back to that woman again. I never went back to her again. So that was just, I mean, so things like this actually do happen, right? And that compose yourself was, I think, like a slap in the face, because I thought, wow, at that time, I didn't know, to me, tuberculosis had all kinds of myths associated with. There was no myth busting. There was no understanding of where are your parents? Are you here alone? Can we get somebody who's at home? And then I had all these questions about, am I contagious? Am I going to pass it on to people? None of those questions were answered. Till later, I found actually, the story takes a happy turn. I found a very, very good doctor, and she was always excellent with me after that. So anyway, those are just examples. Okay. And so bad news is basically information which drastically and negatively alters a person's view of the future. Okay, that's what bad news is. It drastically and negatively alters. And the greater the gap between someone's expectations and the reality of the situation, the worse will be the news. The greater the gap between your expectations and the reality. This is one of the reasons we have to be very careful about the hope we give people. If I want to, for the moment, just make things, oh, this patient is going to cry. So I say, okay, don't worry, everything will be fine. Everything will be fine. When actually everything won't be fine. So later on, when things are not fine, again, it's going to be a huge fall from, the gap, the distance is so much that crash is that much more. Okay. Okay. My question to you, who is the best person to deliver bad news? Who is the best person? The treating
doctor.
Okay. More than designation, it would be the skills. Okay. Family. Who else? Any more? There are 33 people here apart from Pallium Tech and me. So, person with whom the patient is comfortable. Close relatives. Primary treating team. A skilled person, a loved one. Okay, so I'm seeing a theme emerge. There are people who think it should be someone close to the person, someone who says it's the doctor, some people say it's the, so it's either the expert or a person with the skills or someone who's close to the family. So, all of these people. So who is the best person to deliver bad news? Those who patients know, the patient knows and trusts. It could be either family or professional treating team. Those who have the skill of conveying the message. The bad news, remember the doctor, how she gave me the bad news? I never want to hear bad news like that from, if she was the expert, she was the treating doctor. I would never go back to her. Those who can handle reactions effectively. Smriti, compose yourself, was not the right response. My response might be devastation, it might be anger, it might be sadness. The person who is delivering the bad news has to have the skills to deal with the reaction to the bad news. Those who know the disease, prognosis, and treatment. So yeah, sometimes when it's a complex illness, it is better to have a medical person involved because the person will have lots of questions which only a medically trained person can answer. And I don't think as a psychologist or as a, even as a member of the interdisciplinary palliative care team, I should not attempt to answer very technical medical issues, even if I am the person that the patient is most comfortable with. So what I need to then do is do a tag team and say, I'm here with you, okay? But this is a question that I suppose only the doctor can answer. So is it okay if I bring this doctor in? Okay. I need to have a conversation with the doctor and say, listen, she's very upset. So let's handle this delicately. Give the news gently. I'll take care of how she responds to it. That's why the interdisciplinary team approach becomes very, very essential. When should bad news be given? Like we said, sharing information is an ongoing process, okay? So there's no one fixed time. And one of the thumb rules is whenever the patient asks, I want to be told. But provided the patient has been given the opportunity to ask. Patients are not always given the chance to ask. There's a unidirectional information sharing, and then that's it, that's gone. Or sometimes we cop out, we give the bad news to the family and we expect the family to deliver it. So the patient is not even there to ask us for any clarification. The context. Firstly, what do I mean by context? The way you deliver bad news has to be made up of facts. The person has to have a good idea of the medical history and the progress of this person, not just what this report says. What has this person's journey until here? What have been the other disappointments so far? Or what have been the successes so far? Those kind of things have to also be taken into consideration. Environment, quiet room, preferably no disturbance. The person involved, to be done by those who know how to do it. So the content has to be factual. The environment ideally should be in a quiet room with no disturbance, some amount of privacy, and the people present have to be people that know how to do it. Okay. And there's a framework around it. Now, when I'm delivering bad news, after this, I'm going to actually go into a very specific protocol on how to do it, but this is the broader framework, yeah? I have to first declare my agenda. What does that mean, declare my agenda? I have to tell them why we're here. Today, I would like to discuss with you the reports of the tests which we did last time. I'm telling you precisely why we're here, okay? I want to invite the patient's agenda. Before we get started, I'd like to hear what you are hoping to get out of our visit today. Now tell me why these two things are so important, that I declare my agenda and I invite the patient's agenda.
Is expectation setting?
Preparation.
Yeah.
You're preparing them beforehand.
Okay. Clarity, setting expectations. I see some questions in the chat box. Do you mind if I come back to these in a little while? Okay. There's from Shweta and from Indira. I'll come back to those questions. Arya, will you please make note of them so that I can answer later? The two questions from Indira and Shweta in the chat box. Okay. So, yeah, setting expectations, agenda setting helps focus the conversation. Yeah. Why am I asking for the patient's agenda apart from setting expectations? If patients have questions.
To know the patient's state of mind and what is it that they're thinking?
Yes. Now, I have a test result that has come back. It's pretty bad. And now my patient wants to talk to me about why they're not getting enough sleep and how they've been constipated for the last 3 days. What are you hoping to get out of our meeting today? I'm hoping that you can sort out the constipation issue or the insomnia issue. So I sense the agenda mismatch. But does that mean that what she wants to discuss is not important? It's important. I need to address it because that is what is causing that person immediate discomfort. Okay. And if I'm in pain or if I feel bloated or if I've been nauseated, I'm not in a state of mind to receive bad news. So it's very important. One is expectation setting. One is to know what is troubling them right now. And if something can be done with that, deal with that first. Okay. Don't try to give someone bad news when they're in discomfort with something else. And okay. Negotiate the agenda. Now, there may be more on your list than we have time to discuss. Which items do you prioritize as most important? Okay, so now they're saying, yeah, but she's given me a list of things she wants to discuss. And I have to be very clear. We may not have time to discuss all of it. Now tell me what's important to you, most important, and then they'll say, okay, my sleeplessness, this. Okay, let's deal with that. And now if you're okay, we can deal with one other thing. Is that all right? So you're negotiating. So you're not diving in with your agenda and saying, listen, this is the most important thing you have to hear right now because, everything else pales in comparison. No. So declare your agenda, invite their agenda, negotiate the agenda. All right. And then invite other decision makers. This is an important one. Who do you usually rely on to help you make important decisions? Now, again, by asking them this, you're telling them that something important is coming up. Okay. You're letting them know that something significant is going to be discussed. When we discuss your results, who would you like to be present? And actually, this is a question that should have been asked in advance before that person comes there. You're not springing the test results on them. They know that, you probably said, yes, your test results are coming on such and such date. So prior to that itself, say, when we discuss your results, who would you like to be present? Some people prefer to be alone. Some people want to bring a relative or a loved one. Then you also get a sense of who the important people in that person's life are in terms of communication and family dynamics. It may not be the primary caregiver. It might be a friend. Because my primary caregiver might be like that dentist auntie who is such a big, gatekeeper that she's not going to let me get the information. So I might want to come along with a friend instead, who is a little bit more easy for me to be around. Okay. So ask the question and allow them to have that. Now, breaking bad news. Is more information wanted? Okay. Don't withhold information if the patient or relatives want to know. Don't withhold it. I want to know more than this. I want to know, okay, they might have 10 other questions. Don't withhold it. But don't impose information when a patient doesn't want it. It's okay to not give them the full picture at one go. It's absolutely fine. And I'll tell you how to get to that point. I don't want to if you give me relief from pain. The conversation should end there. Because if I say, no, but see, I think it's important that you know that why you are getting these headaches, and what I'm trying to get at is that the tumor is metastasized or something. No, I don't need to know. Just give me pain relief. The person is telling you in no uncertain terms that they are not equipped to handle bad news right now. Please respect it and stop. Now, checking, this is an important one. You have to check patient understanding. Tell me what you know about your diagnosis. Okay? Tell me what you know about your diagnosis. We talked about this in a previous session. Knowing the diagnosis is very different from understanding the diagnosis. Okay? Tell me what you know about your diagnosis. I know that, I have some kind of, I think it's called carcinoma or something. And it's something GI carcinoma, something it's called. I know that. Okay. Or in this case, it's a stroke. What do you have? I've had a stroke. So we've been talking about a brain stroke. What do you understand about the condition? In the case of the GI carcinoma, I will say, you've said GI carcinoma. What does that mean for you? What does that mean? How? I don't know, doctor. I think that means some growth is there somewhere in my stomach area. Okay. So you have to gently prod. Check patient preference for information. So how much do you want to know? Would you like to know more about what you have? Do you want me to explain what GI, what gastrointestinal means? Do you want me to explain what carcinoma means? See, this, by then this person probably knows, okay? But what you're saying is, shall I explicitly tell you what you have? And then wait for their response. Now, warning shot is this is, I think, the key in breaking bad news. It's the warning shot. This is what's going to tell you. So whether the person is ready or not. A warning shot is like this. It is more serious than we thought. So you're not telling them how serious, but you're telling them it's more serious than we thought. Now you are preparing the person for bad news. Or we were not able to dissolve the clot. Now I'm leading up to a more important part of the conversation, which is that maybe the cancer has spread. Okay, we were not able to dissolve the clot, or the heart is weakened. So by saying these things and pausing, I'm going to let this person slowly absorb this information. None of these things is good news. You know it. So now I'm going to gauge how this person is responding to me. Are they tensing up? Are they starting to get fidgety? Are they nodding? What's going on with them? So you have to pause and allow it to sink in, and you have to be prepared for emotions, because by this point, people know that something is up. Okay. And now is when you'll see either despair, anger, silence, sobbing. Sometimes people are just looking at you numb. So you can again do that clarifying and say, would you like me to repeat what I just said? Okay. And there can be quite a bit of, there can even be bargaining and compromising. No, but what if okay, fine. Shall I then try the other treatment, which, we talked about it 2 weeks ago and I said, we'll go for this. So shall we just do that now? So there'll be some pivoting, there'll be some, basically trying to settle down. There could be any number of reactions. At this point, empathetic statements are, again, your key. You have to go to an empathetic statement. I can see how upsetting this is for you. I sense your disappointment and sadness. This must be so difficult for you to hear. You are recognizing their feelings. You're letting them know that you sense their despair and their pain, and you're sitting with them. Please understand that there is a time in this conversation when you're not required to fix anything. At this point in the conversation, you're not here to fix, you're here to sit and hold that space with this person. And this is one of the most powerful things that you can do with patients and families when you're delivering bad news. You have to have the luxury of silence. Because as long as it's all here, it's not coming down here. Now, for a lot of people, and I mean professionals, this is a very safe space. Huh? It's a very safe space. Don't want to come down here. So what we end up doing is filling the silence. There's some silence. Okay, so you know what? I can show you some of your other reports. Maybe I can pull up that case where there's actually been quite a bit of success in this kind of treatment. I'm filling in the gap because of my nervousness and my discomfort. But sitting with somebody in that silence, you've given that warning shot, and then someone might say, okay, tell me everything. Then you tell them everything, or that warning shot itself is enough to send them back. And then you have to sit with that emotion. Please, it's actually empathetic statements are just very straightforward. It's the simplest statements. I see you, I hear you, I feel you, I sense you. Okay. And finish sensitively. After you sit for a while, say, let's go over what we discussed just now. Okay. This is what we talked about. Like avoid abruptness, like someone talked about earlier. Abruptness can be very, very jarring. Review before finishing and offer follow-up and support. Now, I'm going to go into a detailed protocol with you now. So I'm not going to spend too much more time on this slide, because I will take you step by step through a process that is one of the most successful methods of breaking bad news, or actually having any kind of breakpoint conversation. Now, just to let you know that a breakpoint conversation is any conversation where there is a pivotal turn in the illness trajectory. It could be the day that someone starts using a wheelchair. Someone has to start wearing adult diapers. It could be the day that someone needs a colostomy bag. It could be a day that they can never drive again. Or from now on, you're confined to your home. Now you have to be escorted by someone everywhere you go. Those are breakpoint conversations, okay? Those are bad, it's bad news, but not necessarily terminal illness news. So this kind of protocol can be used in any of those scenarios, and some of you might be familiar with it. Sorry, I'm deliberately not answering questions in the chat box right now, because I'll come back. I'll finish all of this and we'll spend some time on that. I don't want to be interrupted when we all get to actually start having a conversation at that point. So I'd rather be done with the presentation by then. Okay, so it's called the Spikes protocol. Okay, and Spikes protocol by Burke. I'll send you, I've got a paper on this for you. I will send it across. So I have 3 presentations that I'll be sending to you through our facilitatory team and through our tech team, along with some papers and documents and learning material that will sort of build on what we've talked about over the 3-4 sessions that I've done with you. So Spike's protocol is this: setting, perception, invitation, knowledge, emotion, strategy, and summary. Okay, and I'm going to take you through each one of them with some actionable ways in which you can do this. Now, first, setting is to provide privacy and give the patient your full attention. Not always possible, but attempt it, at least try. And to ensure comfort, first thing you have to ensure comfort is please introduce yourself by name. How many times have you been to a doctor that has introduced himself or herself to you? No? Indira, you were saying something?
Just twice, I think, I've had the doctor tell me his name and who he is. Otherwise, they assume that you've come to them and
You've come to them, so of course you should know who they are.
you should know who they are. So, yeah.
Yeah.
Very few.
But just tell me, if the doctor comes to you and says, I'm so-and-so and I'm in charge of treating you, would you feel better?
Yes, certainly. I'd feel more trust in the person because
Immediately, with just that sentence. Hi, I'm
Absolutely.
so-and-so and I'm here to take care of you. That's it.
Absolutely.
Half your rapport building is done. Address the patient by name. Asha, Anita, Darshan, I'm just calling out names that I can see right now. What that tells me is that, hey, this doctor's read my file and he's addressing me as a human being. And then say, oh, you've come, and who might this be? This is my mother, Jayanti. Now it tells me that I'm interested, not just in your disease, in what makes up your world. I think I've mentioned it, we've had so many occasions where in palliative care, it's so sad actually, that we ask a caregiver their name and they're like, you're talking to me? Because they've never been asked their names before. And we've talked about this, right? Bystander. No bystanders, no nothing. You are a person, you are probably doing the most amount of work in this whole situation. So let's get the carer's name. Let's get the person accompanying the patient. Let's get their name. You will instantly make them feel at ease by just introducing yourself. It doesn't matter if you are the most famous oncologist in the district. Introduce yourself. Offer them a seat or go to a quiet place. Come, shall we go sit down together? Let's talk. And remove distractions. Say, okay, let me just put my phone on silent. Those are confidence building exercises, right? So that's the setting. So you're doing the setting, you're ensuring comfort. Perception. Assess how the patient perceives the medical situation. And before that, you have to assess their emotional state. If they come into you and they're very rattled, they've just had a horrifying experience sitting in the waiting room. There were no chairs. The patient has had to stand for the last half an hour waiting to come and see you. You know, all of those things are not boding well for this conversation. So assess, how are you feeling right now? I'm really tired. That was a very long wait. Okay, or how are you feeling right now? I'm a bit nervous. Okay. Or, I mean, these are alternate. These are not sequential questions, okay? These are just some options that you have. Given the situation, what are you thinking about? So this could be the second time you're meeting the patient. It could be third time you're meeting the patient. It could be that the family has called you and said the patient is really upset right now because they don't want to come to the hospital. They don't want, so if I'm going home to I'm going to their home. I mean, whatever. These are just these are variations on the theme. How are you feeling given the situation? What are you thinking about? Open-ended questions, okay? Okay, find out what the patient already knows. What do you know about what you're experiencing right now? Okay, I've got a tingling feeling in my leg, this radiating kind of pain and a tingling feeling in my leg. Okay, I don't know. I think maybe, there's some nerve compression or something, because the other doctor had told me that over a period of time, my nerves might get affected. So maybe that's what's happening. Maybe that's why I've got that tingling sensation in my leg. So you at least have an idea of where this person is. Okay, or they're coming to you and they've gotten there, they've spoken with other members of the healthcare team, etc. So you ask them, what have you understood from what you have been told so far? I understand that what I have is fairly serious, but also quite common. And there are lots of treatment options for it. That's what I understand. Okay. So you're hitting the ground running in that sense. You're not giving them information that they already know. You're not assuming that they have information that they don't have. So this is really a very important exercise. Now, do not try to address denial if it is your first meeting. If it's the first time you're meeting them and they're in full denial of their disease, don't try and be the one who's trying to fix it in that meeting. You're going to have to build more trust with that person. See, madam, look at all your reports. Just look at it. This is the oncology department. So tell me, what do you think you have? That's me trying to break through someone's denial. Denial is a self-protective mechanism. If you try to hammer through it, you're going to lose the trust of that person if they're not ready to open up to you. It's like an intruder at your gate. Your gate is there for safety, and this intruder is trying to break it down. Even if that person on the outside is my electrician and my plumber coming to fix a problem that I have, if he tries to break down that gate, I'm not going to let him in. I don't want that plumber and that electrician if they're going to try and break through my front door to come in to fix my problem. Okay, so don't try to address denial in the first meeting. Next, invitation. Ask the patient how much information he or she wants, and find out what the patient wants to know and if the patient wants to know. So this is again going back to that framework that I shared with you earlier, right? So those were the broad principles of working with breaking bad news. Here, we're putting all those concepts into a protocol. So find out what the patient wants to know. What would you like to know more about? Do you want to know everything that is going on, or do you want to just focus on the treatments? I'm getting a sense of what this person is like, right? Some people might say, is my appetite loss also a result of this? Or, between the last two meetings, I've had more and more fatigue. Is that connected to this? So I might be the person who wants to link all these things. Or I might be the person to say, no, everything is fine. I'm just wondering, I think this is the medicine that's causing me to have like some acidity and things. Can you change that? So I want to focus only on the disease, on the medication. So I need to know where this person is at. Okay, what would you like to know more about? Do you want to know everything that is going on? Do you want to focus on the treatments? Okay, find out if the patient wants to know. You can ask them straight up. Are you someone who likes to know all the details? One way of finding out where they are with their with how much information they need is to ask them, is there someone else that you would like me to discuss the treatment plan with, or do you want to talk to me alone? Now, that is a way of also assessing whether they are scared of what's coming or whether they can handle it. I'm the one who's going to have to make decisions about my care, so you may as well just tell me everything that's going on. Or I might say, hey, it's actually my son who is the more, like, he understands this medical stuff better. So I'd prefer it if he was around. What I'm trying to tell you through that is that I'm not ready to receive the information by myself. So these are very simple questions, but it'll give you a very clear way of understanding where the person's mental status, emotional status, how much they know and how much they want to know. Give a warning shot to assess if the patient is ready to know more. And I told you what some of those warning shot things are. Things are not improving quite as we hoped. Would you like to know more? I'm sorry, the test results are not what we were expecting. I'm afraid we're going to have to consult a radiologist. Those are warning shots. So that will also give you a sense of whether they want to stop right here or whether they want to continue and know more from you. So knowledge. Provide information tailored to the individual. Now, I've told you I only want to talk about my insomnia. Let's talk about the insomnia now, okay? But remember to negotiate the agenda and say, okay, it seems like this is the thing that's bothering you the most right now. So fine, let's prioritize this. But at some point, we're going to have to discuss your test results. Okay. Now, deliver information as per the needs and preferences of the person. Please use the patient's primary language if possible. You might need a translator, or you might need somebody to sit and make sure that the person is understanding what you're saying. Very important. Use a similar vocabulary to your patient. If your patient calls it a growth, you call it a growth. If the patient calls it, I don't know, like a tumor, call it a tumor. If the person says spread, you say spread. Okay, so try and match that person's vocabulary and give information in small chunks. Why? Why do we give information in small chunks? Why do we give information in small chunks? Many patients use this thing, okay. Aparna, to that, I'd say, ask them to say, can you tell me more about this thing? Okay, this thing, because you could be talking about two different things, and that's a possible misunderstanding point. I don't know why there are balloons coming out of my screen. Okay, so what is this Zoom feature?
I guess we would chunk Smriti so that the patient is not overwhelmed with all of that information and they have time to ask questions also.
That's right. That's one of the big reasons, yes. Why else? Absorb information, let it sink in, so on and so forth. Yeah. One of the biggest barriers to understanding is high emotion. If I'm extremely emotional right now, it's unlikely that I've heard you properly. When you're very, very upset or very angry, do you clearly hear the person in front of you? You don't. So that's another, and brain fog, correct? So this is another reason why we need to slow down and give it in small chunks. So to let it be absorbed so that they can ask questions, so that it sinks in, and also because there's a lot of emotion at that point. Okay. Okay. And avoid medical jargon. I mean, that's quite logical why we avoid medical jargon. State issues relevant to the patient honestly and clearly. So not brutally, not abruptly, honestly and clearly. Here is what we need to be prepared for. Now, oftentimes, one way of going into it is talking about the trajectory. What are your days going to look like from here on out? I think maybe we're going to have to think about one of your children coming to live with you. I think perhaps we're going to have to think about, getting an attendant for yourself. What we need to be prepared for possibly is maybe a couple more hospital admissions. So those kind of things, okay? And here is what we are doing for this condition. And basically, you're also showing competence. This is what we're doing for this, okay? So for what we're doing now to handle this is XYZ. Now, these are medical terms. So a lot of this may not apply to people like us who are non-medical people. But what we're doing for this, forget condition, we can say situation, is the psychosocial support, right? What we can do is maybe we can make your home more wheelchair accessible. Maybe we can bring in a consult with our physiatrist who will tell us, to put in some mobility assisting devices at home. So those kind of things are also possible. Okay. Emotions, respond with empathy. So first of all, before we respond with empathy, I would say explore and identify the emotion. Make sure you identify the emotional correctly. If you have misidentified an emotion, that is not going to end well. Okay. I can see that you're very sad. I'm not sad, I'm angry. So make sure you identify the emotion. How are you going to identify the emotion? By questions like these. Tell me what's going through your mind right now. What's your biggest concern at this point in time? Is there anyone in your family you'd like me to call? These are ways to get a better understanding of what they might be feeling. Okay, so identify the emotion. Identify the cause of the emotions. Cause of the emotion. Identify the cause of the emotion. Sorry, obviously that grammar is wrong. Identify the cause of the emotion and link the two. Okay. What is the cause? Why am I feeling shocked because of my test results? Why am I feeling upset? Because you've suddenly told me that I can't live alone anymore. I have to have an attendant, or I have to go and live with my grandchildren or my children. So you're linking, what has caused the upset, and you're linking it. So this result must have come as a shock. Losing independence must be upsetting. Okay. And then empathize. I'm sorry, I know you were hoping for better news. I can only imagine how difficult this is for you. So explore, identify the emotions, link it to what the cause might be, and empathize. Okay. And also I've added one more thing to this is reassure. We will do everything we can to help you. Reassure doesn't mean everything is going to be all right. Please do not say that. Reassurance comes through these things like this. We will do our best to take care of you. You are not alone. We're here with you. We will talk with your family regularly. These are reassurances that you're giving without over-promising. So don't over-promise, don't provide false reassurance, because then you're extending the gap between the expectation and the reality. And then it's just the bad news is going to be worse for them to absorb the next time. And finally, strategy and summary. When the patient is ready, present treatment options and make decisions together. So summarize. So when you came in earlier today, you told me that these were your concerns. After that, we discussed this, and the reports, as we have just gone over, indicate this. Okay. Create goals of care. These are important questions. What is acceptable to you at this point? What is not acceptable to you at this point? What would you like to be able to do? And what is a priority to you? These will tell me who this person is and what their treatment options should be as a result of these things. Let's just spend a couple of minutes on these questions, okay? Because I think, to me, these are the most important questions you can ask this person at this point in time. What are some of the responses that you can get? I'd like for you all who have experienced an illness or who have experienced, a loved one being sick. If you were to imagine the scenario being asked this question, what is acceptable to you at this point? What are some of the things people might say? What is acceptable to you at this point? What is acceptable to you? That medicines will cure me, facing the truth. Okay, let me give you an example. Okay, I accept I will lose my hair with chemotherapy. No. I'm asking you all to put yourselves in the place of the patient, okay? You're right now the patient, and you have been asked what is acceptable to you. I have given you one potential response. I'm okay to lose my hair if it means that I will get better with this chemotherapy. I'm okay to feel nauseated as a side effect if this is the chemotherapy that is going to actually impact my cancer positively.
I'm okay to undergo therapy, psychotherapy, to understand my feelings and emotions as I deal with this.
Very good, very good. Okay, I'm okay to lose hair, but don't want meds that will make me lose my cognition. Excellent. There you go. You've just told me what you will accept and not accept. Next question. What is unacceptable to you? What is unacceptable to you?
Using a bedpan.
Yeah. Oh my God, I had those battles for months. And it sounds like you know what that's like also. Yeah.
I can't tolerate the pain.
I can't tolerate the pain. The pain is unacceptable. Okay. I can't be dependent. It will be acceptable if more information is shared with caregiver, but not with me. Okay. I don't want to be surrounded by machines and sounds all the time. Yeah. I just want to sleep and rest peacefully. Being immobile. Sympathy and pity is unacceptable to me. I don't want to become a charity case. I will not accept becoming a burden on my family. Okay. So you see why these are really important questions? What is acceptable to you at this point? What is unacceptable? And to me, these are the fundamental questions to ask somebody if you really want to know who they are. Okay. And these are dignity associated things. Yes, you're absolutely right. These are all dignity associated issues. And at this point, please remember, when someone has lost control of their life because a disease has taken over, the only thing they really want to hold on to is a sense of dignity and autonomy. You'll find a lot of people, especially people in their 30s and 40s who have got parents who are unwell, who will come and say, my God, they're so stubborn. He's so stubborn. If he just listens to me, so stubborn. Why is that person being stubborn? It's literally the only thing left that they have control over. I will not move out of my flat. I will stay here with my 5 dogs. I will not come and move into your house with you, even though you have 10 maids to take care of me. I'm going to stay here. Why? It's their home. It's the place where they assert control. So disease takes control away. Please understand that when a person is being difficult, what they're fighting for is a little bit of their own territory back. Okay. So, yeah, too many questions. Let me be myself. Okay. That also tells you something, doesn't it? They need time to process. All right. So let's get this going. We have some time. All right. What would you like to be able to do? I would like to eat by myself without having a feeding tube. What is a priority to you? It is important that I stay conscious so I can talk to my grandchildren. Priority to me is to stay at home. I want to be in my own house. Priority to me is that I don't want my priority right now is to get my bank work in order. These are the things that also tell me how far in their understanding of their mortality the person is. Okay. So remember that none of these questions are directly assaulting somebody, but these are what we call landmark questions. Through these questions, you're understanding the territory of their mental map and their emotional landscape. Okay. Now, once you know this, okay, fine. It's acceptable for me the pain is intolerable, someone said. Okay. So these are some of the options open to us to treat your pain. Someone says, okay, it's acceptable for me to have a catheter. Okay, in that case, this is what we're going to do. We can schedule an appointment with so on. If you choose this, then the next steps will look like. Okay, so we've understood their map, we've understood their territory. Now we're going in a direction. Okay. Now, I will need, we're going to spend about 10 minutes on this. So can someone please volunteer to read the clinical narrative? Anybody?
I'll do it.
Okay, thanks, Indra.
Mohan, a 40-year-old man presenting with pain for a month and incessant vomiting for the last 2 weeks, comes to the OP. Recent investigations indicate malignancy. He has 2 children who are 8 and 10. He lives in a joint family with his brother's family. He has been asked to do a CT scan but cannot afford it. His wife is anxious but doesn't say much. His brother, who accompanies him, is upset that the patient is only worsening. He is also supporting the family financially. Mohan asks you, what is going to happen next? How much is the treatment going to cost? Am I dying? Okay, that's all.
Sorry, thank you, Indra. Now, using this narrative and what we have just talked about, I'd like you to apply these steps in Mohan's family's case, okay? So this is the spikes protocol. I have listed the the important things we need to look at under each. So one person does not have to go through the whole thing, but let's take it one at a time. Setting, ensuring comfort. This family has just walked in. This man with his wife and brother have just walked in. What are you going to do to ensure his comfort? He's come to the, he's come to the OP. He's come to the outpatient unit. Remember that, okay? He's come to the OP. So he's not come to an inpatient facility. You're not at his house. So what will you do to ensure his comfort? Am I not seeing the,
Introduce myself, or I am so and so, and ask them all to have a seat or arrange for chairs for all of them to sit down and offer some water.
Yeah, great. Oh, there's a lot of stuff in the chat box. Yes, wonderful. Okay, so that's a great way to start. Introduce yourself, offer water, coffee. Neeta, instead of saying rapport building, tell me what you will actually say. Inform him in the presence of his family. No, we're not there yet. We're not there yet. We're still doing the setting. We're still setting the stage. Okay, so shut the door of the consulting room if possible. Introduction. Yes, excellent. Next, assess emotional state and find out what he knows. What is Mohan's perception? How will you do that? How will you do that? What are your complaints? So what do you think is happening? What is your routine like? Ask the family how they're feeling today. How are you feeling now? Find out what he knows. What is going through your mind? Ask him what he thinks is happening to him. Great. Perception. So Mohan comes in and he says, I'm in so much pain and it's just not going. And this, can you imagine what incessant vomiting is like? It's one of the worst possible things to have to live with. So in his case, I may not even, I might ask him how he's feeling, but it's kind of staring me in the face as well, right? So I might just want to focus on very quickly. He's not somebody who's obviously going to be able to speak a lot because he's nauseated. So then I need to focus on find out what he knows. Now he's come with his brother and his wife. I might also speak to the two of them. What has this last month been like? We can see that he's really unwell. What have some of his complaints at home been? Okay. All right. Invitation. What he wants to know, if he wants to know. What he wants to know and if he wants to know. Remember declaring your agenda, inviting patient agenda, and negotiating the agenda. Yeah. And some of the questions there were, would you like to talk specifically about your treatment, or would you like to talk about the bigger picture of what is going on? Right? What do you want to talk about? Do you have any queries regarding your present condition? Yeah. Ask if he's had a chance to learn about his investigation reports. Yeah, that's a good way to do it also. Okay. Okay. There's someone in the room who might be speaking for him. The brother. There's a good chance that you're going to have most of your conversations with the brother. Yeah, I mean, yeah, Swati, that's also a good question. We need to make sure the patient gets to speak. Okay, so now here is something that he's already asked you. Okay, finally the patient is talking to you. What does he want to know and if he wants to know? He wants to know this. What is going to happen next? How much is my treatment going to cost? That's what he wants to know. What is going to happen next? How much is the treatment going to cost? Last question out. We'll come to that later separately. What is going to happen next? How much is the treatment going to cost? The man cannot even do a CT scan. He is financially dependent on his brother. Now, what are you going to say? You are at this section now, knowledge and empathy. What is going to happen next? How much is the treatment going to cost?
And say that I can sense that you're worried about what's going to happen next and how much this is going to burden the family financially. And for the first, I think we will need to go ahead with the scan to find out more details about what's going on inside you.
Then I'm the brother and I say, Aparna, what is the point of all these tests if he's not getting better? The brother may lash out back at you because he's already upset, huh? So he says, all that is fine, doctor, but what's the point? In the last few weeks, he's not even showed any sign of improvement.
But Smriti, at this point, doesn't it mean that the doctor has not spoken about the patient's likely prognosis in the previous conversation?
Yeah, it's quite possible. So I think here also what is important is that I agree with Firdaus. What's important is they need to be told the cost, how it will direct the near future treatment and why it's important. Absolutely. Now, I would say it's really important for us to understand what they have been told by other people. Okay, this is again, so please understand something, that this is sequential, but you might have to jump back and forth. Now I want to go back and say, All right. What is going to happen next? Tell me, you've been through this, you've been living with this illness for a while, and you've seen a few doctors. Tell me what the other doctors have said to you. Okay, that's one way to start. And the other thing that you need to say is, what is going to happen next? How much is this treatment going to cost you? This is where your empathy also needs to come in and say, this is obviously a very distressing time, but before I answer those questions, I need to understand a little bit more from you. What have the other doctors said so far? What are your expectations from this treatment? When you say that your brother hasn't gotten better, what does better mean? And you'll say, his pain, so what does the word better mean to you? Okay. Or yes, that doctor told us to start taking this medicine and that vomiting will stop, but the vomiting has not stopped. Okay, let me take a look at that. So when in doubt, always go back to their perception. Always go back to what they know. And say, and always reassure. You know those reassuring things. I'm here. I'm going to try my best to take care of you. But for me to be able to take care of you, I need you to answer a few more questions. So you have to mix that reassurance with the eliciting of answers, right? So you can mix those up and say, I'm going to try my best to make these symptoms get better. But I need to know what treatment you've had in the past and what has worked and not worked. And maybe we can then understand why you're not feeling better. So I'm now slowly drawing the brother in. I'm telling you I'm here to help you. I'm telling you that I need to understand a little bit more. Okay. And I could even say that, so people say, yeah, what's the problem? Every doctor keeps saying this. It sounds horrible that you've been through this so many times. I'm going to try to make sure that doesn't happen again. Okay, so it's going to take some back and forth. Now I'm mindful of the time, but so this is something that why I went through this case with you is to show you that it's not a straightforward sequential protocol, but each of these gives you certain tools that you can go back and forth with. Just like grief and other things, you'll find that people will accept their diagnosis and suddenly the next day they're in denial. They'll accept their diagnosis, suddenly they'll be angry the next day. So be prepared that you might have to go through these quite often. And acceptance is a lifelong process, yes. And then summary strategy, that of course will, and you have to keep clarifying, keep clarifying. Am I understanding you right? Am I understanding you right? When emotions are volatile, please remember that sometimes there might also be distorted facts coming out. You also have 3 people in the room. You have to also, the wife is looking anxious. Why is the wife anxious? Can you say for a minute, can we just, can I hear from the lady? I know she's the primary caregiver. What does your day look like on a daily basis? She'll say, my concern is he's just, because of his nausea, I don't even know what to give him to eat. So you have to elicit the concerns of everyone in the room. Not everyone's concerns will be the same thing. For all you know, the brother, his anger is also coming out because he's the one financing this whole thing. He wants to know how much more he has to pay. And whether that financial, that financial cost will actually result in something positive. So he's coming from that as well. They're living in a joint family. He's got his own family to look after as well. Okay, all right. Now, when patients are angry, I'm going to go through this quickly. Make time and space and listen. It's not easy. I know sometimes when someone's yelling at you, the last thing you want to do is sit down and listen to them. But when someone is, especially when there's a lot of blame and, this didn't happen right, that didn't happen right, don't accept blame or rush to justify, because both of these will escalate the issue. When I say don't accept blame, I'm not saying deny it if you're responsible. I'm just saying that in that moment, say, yes, this is my fault. it will escalate the issue. At the same time, when you rush in to justify, no, but we did it because that day you were in pain. So that was the most important thing we had to deal with at that. Don't justify it. You're just going to irritate them more and it's going to get worse. So first of all, try and invite them, say, I'm here to listen to you. Can we do this in another room? Encourage them to sit down because that is a less challenging posture. It's very hard to throw a punch when you're sitting down compared to when you're standing up. Okay. So it's a less threatening posture. You also sit down and look beyond the anger to the fear and grief and concern, because behind anger is always fear. It's always grief. There's something else. There's some concern of some sort. Like in Mohan's brother's case, it could very well be the fact that half his salary is going here. Okay. Acknowledge the underlying emotion. Say, you are angry. I know you're really angry right now, but I'm here to listen to you so we can address what is making you angry. Maintain body language that conveys receptivity. So avoid looking at the file or looking at the window, looking out. You have to maintain some kind of engaged body posture. Be mindful of eye contact. It's not coming across as a challenge. Eye contact is good, but not when you're staring at them back. Okay, that's going to be taken as a challenge. Promise to investigate any unresolved issues and to talk again. And if you do that, make sure you talk again. Okay. And when you are angry, there'll be times when you're angry. Buy time to bring down your own emotions. You're in a confrontation right now. You're getting more and more angry. Say, okay, let's get us all a glass of water. Recognize your underlying emotion. You're feeling defensive. You're worried. What if I did actually mess that up? There has to, this is something that actually has to predate this setting. There has to be some cohesion in the team, because you need team members to also just be available to back you up. Don't expect the issue to be resolved with one meeting. And if you're doubtful of regulating your emotions, if you feel that you're getting more and more riled up, it's preferable to get someone else to handle the situation and say, I may not be the right person to speak to you right now. I don't want to say something that I don't mean. So I'm just going to get my colleague, but I will come back to you and we will have a conversation. Okay. And then a discussion with the team to debrief. It's very important when there's an unpleasant experience to debrief with your team. Why did that happen? What were the gaps? Not with blame, not with judgment or criticism, but to just say, how did this happen? How could we handle something like this better the next time and so on? Okay. And dealing with difficult emotions, sometimes unfocused anger or fear converted into anger may be directed at you. Be ready for it. It's okay. The best way to deal with this is to listen without interruption. Don't interrupt. Just let them talk, because in that itself, the anger starts to reduce. Okay. And venting is a good way to release that sort of pent up anger. Some patients become uncommunicative when they're angry and they withdraw. You have to consider why that might be happening. Maybe they're on some medication. Maybe there is a situation going on at home that is worrying them. Again, total pain. What are the 4 boxes of total pain? Maybe that's why they've become uncommunicative and withdrawn. Caregivers often feel guilty, inadequate, or helpless. Acknowledge something positive in what they did and said. Under the circumstances, you're doing a fantastic job. This is such an important one. You prop the caregiver up, it'll really take the family far. And say, under the circumstances that you've been operating on, I think you're doing remarkably well. I don't think anyone else could have done anything better. Avoid making commitments to relieve momentary distress. Make only those that are realistic and within your capacity to deliver. When someone is looking agitated, I'm not able to do this. I'm not able to get through to this doctor. I'm not able to do that. Don't turn around and say, okay, you call me anytime. Please don't say that, because they will call you anytime. And then you're in a fix. Make sure that what you're offering is realistic. Okay. And hope should always be realistic. We will talk about this in a different session, because hope is it's another one of those things like dignity that needs its own time. But hope should be realistic. And I'll just give you some examples about that. Okay. So finally, do's and don'ts. Don't avoid eye contact. Make eye contact. Don't rush in to tell the truth. You have to gauge the readiness of the patient and family to accept the truth. And bad news is given in small doses. That is decided by the size of the dose is decided by the patient. Don't attempt to answer questions like, when will I die? How long do I have? This is a very difficult one. A lot of doctors are asked these questions. The way to handle that is to ask a question in return saying, what makes you ask me that question? Is there anything in particular that you want to do? Is that why you're asking me this question? Okay. People will tell you. People will tell you. This idea that you have to answer them with a number is wrong. What they're asking you when they're asking you, when will I die, is not, they're not asking you, am I going to die tomorrow? They're asking you to, that's like their reverse warning shot. It's like them ask, will I have time to attend my daughter's wedding? Will I be around to see my son graduate high school? That's the question they're asking you. So by asking them, what makes you ask me this question? Is there something in particular that you're thinking about? That will tell you why they're asking. Now, when you get that answer from them, what they're also asking for is prognostication, the trajectory of the illness. Yeah. So then what you do is you break it down into short-term, mid-term goals. And say, we're going to make sure that you stay mobile at least for the next few months. So you're not taking away hope, you're providing realistic hope. Okay. Don't ask leading questions. Your pain is better now, isn't it? Ask open-ended questions. Don't minimize or compare patients' problems with others. It's like, I remember in COVID, well, not just in COVID, but this happens a lot. Mr. Gupta, yeah, I know this is a little bit inconvenient to have this condition, but see that family. 3 of them are sick. That kind of comparison does not help. Oh, once I had a patient, he was far worse off than you, and he made quite a remarkable turnaround. Because what you're doing is you're diminishing this person's concern right now. Okay. So you have to acknowledge and normalize the patient's emotional experience. Anybody in your position would perhaps feel this way. Considering what you're going through, it's normal to feel like this. Those are your responses. Don't give false hope. Give realistic hope. And realistic hope is often in the fact that you are accompanying them no matter what. Okay, your disease may be progressive, but I'll do my best to keep you comfortable as long as it's needed. You can even keep you comfortable sometimes scares people. So you say, you'll be able to walk. You will be able to eat and take care of your own needs. Those are things that if you're able to assure them of it. Don't assume. A lot of people assume that the person's physical symptoms are all they're worried about. Ask what their concerns are, because their concern could very well be what their children are going to eat tonight because of their financial constraints, or the fact that the parents are not at home, they're in the hospital. That could be the concern on their mind. Okay, so these are just communication guidelines. Now, Robert Buckman is the guy who came up with the spikes, and he said, if we do it badly, they may never forgive us. If we do it well, they will never forget us. And I think this is the hallmark of why communication is so important, because you remember all the good doctors, the good healthcare providers you meet are people who've actually taken the time to see you as a person and who've gotten to know your story and who've asked you things that are important to you. Okay, so we've covered a lot of ground. So I'm sorry, we don't have too much time. If some of you want to stay back and have a conversation, that's okay. We can stick around for another 5 minutes. Those of you who have to go, you're welcome to exit. But Arya, I'll just take 5 minutes to sit with the group. Shalaka, go on.
Yeah, Smriti, that was excellent, because I actually go through this on a daily basis with many patients around the country. But I would like to learn a little bit more about how to discuss prognosis. And because our doctors in India are not discussing prognosis very openly, because I come from a patient advocacy and patient, education awareness platform, a lot of it falls on us. So I would like to learn more about it, even if I know you don't have time, but if there's some reading material that you can recommend or videos you can recommend. And the second thing I wanted to highlight here is I also deal with a lot of young patients,
Hmm.
you know, mostly in the 20s and early 30s. Uh, a lot of these things I think I would have to tweak to their age because their issues are different and we are dealing and I'm talking about a condition that is likely going to kill them in their 20s itself. Um, so like this session, the last session, I realized that I have been making a lot of mistakes, and I'm going to start course correcting now because I'm learning so much from it. And one more thing I wanted to highlight is that uh, doctors in India tend to, especially the male doctors, tend to talk down to female patients.
Yep.
Um, and they sometimes don't even make eye contact with the female patient. They talk directly to the male caregivers or whoever is or maybe the senior person in the room. And because I deal with so many young people, I know that is one of the most common uh, complaints in doctors communicating with them. And literally, not even 10% of what you have taught us today is what I see on the ground happen. Not even to myself. I've been a patient for a long time. Not one doctor has spoken to me this way. So, I hope you're teaching doctors all this. You're taking sessions with doctors. Yeah, I think this is far more important for the doctors.
I have a session with pulmonologists next week.
Okay, right.
Yeah.
Okay. This is so much more important for them.
Yes, and in fact, I'm going to be leaning on you because I need some, lived experience also in this, and so I will get in touch with you about that, Shilaka. But you will, that's why palliative care reaches less than 4% of people in the country. I just want to say that one of the main aspects of palliative care is communication, and like I said earlier, now this is part of the medical undergraduate curriculum. So hopefully more people will step up to this. The intersectionality of gender and stuff is a massive issue. There's no doubt about it. As far as the prognostication thing is concerned, we are doing a session on end of life care, and we're doing a session with advanced care planning with Rupur Sahani. So he talks about prognostication at that point, and he's actually the best person to talk to you about it. Very quickly, because I know that there were some questions. Shweta had said how to respond to patients who question back, like, how do you think I'm feeling? Usually they become tired of answering this question, sometimes especially when they feel we can't help them. Also, when they've been asked that question very perfunctorily, it's like a tick box. That is your cue to acknowledge their anger. I'm sensing your anger because I asked that question. Is it because everybody asks you the same question? It's just that. Just acknowledge it with empathy. I can see that this question has made you angry. Can you tell me why? Then it's because everyone keeps asking the same question. But that's your cue. It's inviting you to a conversation, okay? There was one more. Indira, you had a question for me. I'm sorry, I seem to have lost it in the chat box.
I think I was asking, shouldn't doctors be trained to give bad news gently? I mean, I think I'm just wondering if it's not a part of, I don't see it.
Yeah.
I don't see it even, I mean, having very close friends who've gone through their cancer journeys. I've found that the news is given so abruptly. I'm waiting outside. My friend has gone in and she comes out and says, let's go and get lunch. And I said, what did she say? And then she says, I said, why didn't you call me in? She said, oh, the doctor said you look like the type who'll be able to take it.
Oh, take it.
I mean, what kind of assumption is that? I've gone with her. I'm right outside. And, she said, I would have called you, but before I knew it, she told me this. So anyway, let's deal with it. But I was so shocked. I mean, this is almost 10 years ago, but I don't know if they've improved,
Unfortunately not. But hopefully, with this now becoming something that they have to mandatorily study, and also I feel like now with the sort of um, uh, animosity between people and the healthcare system is also realizing that there is a sense in cultivating goodwill in people. Where did you have reviews, online reviews and stuff earlier? Now those kind of things are mattering to people. So it's going to take a combination of these things for this to get better, but it's a basic skill. It was never taught, Indira. It was never taught. And even the best of us the best amongst us who are communicators, who are articulate in real life, it's very tricky situation there to be able to break bad news. It's one of the most difficult things in the world to be able to do with any amount of grace, because also it requires a lot of emotional quotient on your part, a lot of emotional
True.
intelligence.
True.
And so, it's a matter of several things coming together. Sorry, I'm just going to answer the last question, which is, I think it was about caregivers telling you not to tell. So that's one thing that we couldn't cover today, unfortunately, which is collusion. But let me just say what collusion is. It's a conspiracy between the family and the doctor to not tell the patient. It's usually at the request of the family.
Family.
And the reason why is they lose hope. I mean, 99% of the time, that's the answer I get. Why don't you want them to know? They will lose hope. They will lose strength. They will give up. They can't take it. Same thing that doctor assumed about your friend, right? With collusion, again, I would say, don't try to push through it forcibly. Because you will, if you lose the confidence of the family, they will never let you near the patient again. Okay. So if you remember that the lady who didn't want her daughter to talk to the father, that is collusion. That is collusion. That's classic collusion. Except that in collusion here, we are also recruiting the health system. So here, not only she's not letting the daughter talk to her, she's not letting me as the healthcare provider talk. My go-to would be to sit with the person who is colluding to tell me, what are you really afraid of? I'm afraid that my mother will lose hope. Tell me more about your mother. Oh, she's no, tell me. I mean, she raised you. She's brought up your family. Clearly, she's been a central figure in your family. How has she handled crisis before? Has she handled crisis before? Yeah. I've had people tell me that their fathers, who are retired army generals, cannot take bad news. And I'm like, your dad has fought in wars. He can take bad news, but tell me what you're worried about. So can you take more in detail about collusion? Well, it'll have to be another next session. We'll do an extra communication session. So my question really, I mean, I'll cut it short now, we're out of time. But in collusion, my recommendation would be to sit with the person who's gatekeeping and say, tell me more. And the fear that they're attributing to the patient is usually their own. It's not that the patient will lose hope. It is that they will lose. They will lose. Because in spite of their best attempts, they have not been able to save their loved one. It's a matter of their own failure. It's a matter of their own, feeling like they didn't do enough. A lot of the times, it's their own guilt. Takes a little bit of skill to navigate that. But yeah, if we can take the permission of Shri Priya, because Shri Priya is my boss, okay? And I'm very scared of her. So if she allows it, we'll do a very quick, not such a long session. Perhaps we'll do an hour or 45 minutes of something, or just on collusion, and we can put that in. So Arya, please convey that to my boss. And thank you all very much. You've all stayed 15 minutes late, but thank you all for a very interactive session. I will send you all the learning material across and the PowerPoints as well, so you can use them. And I hope you find them useful. All right.
Thank you.
Thank you, ma'am.
Thanks.
So much, ma'am.
Thank you all. See you on the next session.